Approach to any disease from MIT perspective of scientific homeopathy should be done by exploring the molecular mechanism of pathology underlying that condition, and correlating them with the symptoms given in the homeopathic materia medica as far as possible. Such a study should also explain how the molecular imprints of drug molecules work as therapeutic agents by acting as artificial binding pockets for diverse types of pathogenic molecules involved in the disease process. Obviously it will be a tough task, as we lack sufficient data regarding the molecular mechanism of most diseases, and allo regarding the molecular constituents as well as biological targets of most of the complex drug substances used in homeopathy. Moreover, we know very little about the biomolecular mechanisms that underlie the multitudes of objective and subjective symptoms collected by drug proving and listed in the homeopathic materia medica. As such, only a very generalized and limited explanation demonstrating the MIT approach could be expected here. Metabolic syndrome has become a major lifestyle-related health issue of modern man, probably due to stressful life, lack of exercise and changed food habits. Metabolic syndrome is a cluster of common abnormalities arising from persistent high levels of cortisol in the blood. This syndrome includes hyperglycemia, abdominal obesity, reduced high-density lipoprotein cholesterol levels, and elevated triglyceride and blood pressure. The common characteristics of metabolic syndrome and hypercortisolemic conditions such as Cushing's syndrome suggest that the pathogenesis of metabolic syndrome and central obesity might involve prolonged and excessive exposure to cortisol. Metabolic syndrome was originally described as insulin resistance syndrome. The components of metabolic syndrome are associated with endothelial dysfunction and atherosclerosis and increase the risk for type 2 diabetes mellitus as well as vascular morbidity and mortality. It is estimated that about 1/4 of the world's adult population has metabolic syndrome. Metabolic syndrome is diagnosed when 3 or more of the following parameters are present. Waist circumference greater than 102 cm in men and greater than 88 cm in women, triglycerides of at least 150 mg/dl, HDL cholesterol less than 40 mg/dl in men and less than 50 mg/dl in women, blood pressure of at least 130/85 mmHg, and fasting glucose of at least 110 mg/dl. It is unclear whether a single primary abnormality triggers a cascade of diverse events that lead to the manifestation of the components of metabolic syndrome. Because the diagnostic features of metabolic syndrome are shared by Cushing's syndrome, which results from endogenous or exogenous hypercortisolism, it was proposed that cortisol contributes to the pathogenesis of both states. Although only mild hypercortisolism occurs in metabolic syndrome in contrast with Cushing's syndrome, it was also suggested that inhibiting cortisol action could provide a novel therapeutic approach for metabolic syndrome. Indeed, preliminary data suggest that circulating cortisol concentrations are higher in patients with metabolic syndrome compared with healthy subjects, both in basal conditions and during dynamic stimulation. This difference is more evident in patients with metabolic syndrome and hypertension or impaired glucose tolerance. Furthermore, weight loss normalizes cortisol levels and improves insulin resistance. Despite the fact that cortisol levels are within the normal range, there is evidence of increased activity of cortisol in the periphery and dysregulation of the hypothalamic pituitary adrenal axis. Differences between Cushing's syndrome and metabolic syndrome also need to be emphasized in Cushing's syndrome. Once the tumor is removed, symptoms improve in the metabolic syndrome, weight loss reverses both hypercortisolism and phenotypic abnormalities. Cortisol appears to play a role in adiposity in metabolic syndrome. Elevated serum uric acid levels are shared by metabolic syndrome and Cushing's syndrome. Increased exposure to cortisol contributes to increased fat accumulation in visceral deposits of fat. Increased cortisol serum overnight levels are also associated with insulin resistance. Some studies showed elevated cortisol levels in situations such as work stress and unemployment. Others reported that chronic life stress results in subtle hyperactivity of hypothalamus-pituitary axis leading to intra-abdominal adiposity and development of metabolic syndrome. Patients with metabolic syndrome appear to have higher urinary excretion of cortisol metabolites compared with healthy subjects. In vitro, cortisol appears to increase lipoprotein lipase or fat-storing enzyme levels in adipose tissue and particularly in visceral fat. Cortisol, also known as stress hormone, is a very important hormone produced mainly by the zona fasciculata of the adrenal cortex in the adrenal gland. It is produced in other tissues also in smaller quantities. It is released with a diurnal cycle and its release is increased in response to stress and low blood glucose concentration. It functions to increase blood sugar through gluconeogenesis, to suppress the immune system, and to aid in the metabolism of fat, protein, and carbohydrates. It also decreases bone formation. In general, cortisol stimulates the synthesis of new glucose from non-carbohydrate sources. This is known as gluconeogenesis, mainly in the liver, and also in the kidneys and small intestine under certain circumstances. The net effect of cortisol is an increase in the concentration of glucose in the blood, further complemented by a decrease in the sensitivity of peripheral tissue to insulin, thus preventing this tissue from taking the glucose from the blood. Moreover, cortisol has a permissive effect on the actions of hormones that increase glucose production, such as glucagon and adrenaline. Cortisol also plays an important, but indirect, role in liver and muscle glycogenolysis, the breaking down of glycogen to glucose. Elevated levels of cortisol, if prolonged, can lead to proteolysis or breakdown of proteins, and muscle wasting. The reason for proteolysis is to provide the relevant tissue with building blocks for gluconeogenesis. The effects of cortisol on lipid metabolism are more complicated since lipogenesis is observed in patients with chronic, raised circulating cortisol levels, although an acute increase in circulating cortisol promotes lipolysis. The usual explanation to account for this apparent discrepancy is that the raised blood glucose concentration through the action of cortisol will stimulate insulin release. Insulin stimulates lipogenesis, so this is an indirect consequence of the raised cortisol concentration in the blood, but it will only occur over a longer time scale. Experimental studies with cortisol inhibitors further support the role cortisol in the pathogenesis of metabolic syndrome, and might provide novel therapeutic approaches in patients with metabolic syndrome or obesity. The components of metabolic syndrome are associated with endothelial dysfunction and atherosclerosis, and increase the risk for type 2 diabetes mellitus as well as vascular morbidity and mortality. It was also suggested that inhibiting cortisol action could provide a novel therapeutic approach for metabolic syndrome. Indeed, preliminary data suggest that circulating cortisol concentrations are higher in patients with metabolic syndrome compared with healthy subjects, both in basal conditions and during dynamic stimulation. It was also proved that reduction of body weight normalizes cortisol levels and improves insulin resistance. Emerging data suggest that patients with metabolic syndrome show hyperactivity of the hypothalamic pituitary adrenal axis, which leads to a state of functional hypercortisolism. The cause for this activation of the hypothalamic pituitary adrenal axis remains uncertain but may be associated with chronic stress, which is associated with increased circulating cortisol levels and greater responsiveness of the hypothalamic pituitary adrenal axis. Increased exposure to cortisol contributes to increased fat accumulation in visceral depots. Increased enzyme activity in adipose tissue and liver might contribute to the development of several features of the metabolic syndrome. Central abdominal obesity is one of the main components of the metabolic syndrome. Cortisol appears to play a role in adiposity in metabolic syndrome. Increased urinary cortisone-cortisol ratio in women with increased abdominal fat compared with those with peripheral fat distribution was observed by researchers, suggesting an increase in the peripheral metabolism of cortisol. Interestingly, cortisol clearance seems to be inversely correlated with insulin sensitivity, and this correlation is independent of body fat. It is also well documented that glucocorticoids promote the differentiation and proliferation of human adipocytes and that their receptors are more abundant in visceral than in subcutaneous adipose tissue. Increased cortisol levels are also associated with insulin resistance. Higher cortisol concentrations were related to a reduced insulin secretion. Hypertension is one of the most distinguishing features of metabolic syndrome as well as hypercortisolism. Many studies reported an association between cortisol and systolic and diastolic BP levels. This correlation might be attributed to the effect of stress, which is associated with the activation of the HPA axis and sympathetic nervous system. Indeed, patients with metabolic syndrome and hypertension appear to have higher urine levels of both cortisol and catecholamine metabolites than healthy individuals. A possible mechanism by which cortisol elevate BP seems to be an increased responsiveness to vasoconstrictors along with a decreased vasodilator production. Obesity, a common finding in both Cushing's syndrome and metabolic syndrome, is also associated with hypertension. The possible underlying mechanisms include volume expansion, increased cardiac output and systemic vascular resistance, increased sodium reabsorption, increased activity of the sympathetic nervous system and the renin-angiotensin-aldosterone system, high leptin levels and concurrent leptin resistance. Patients with metabolic syndrome as well as hypercortisolism frequently have elevated blood glucose levels. In patients with metabolic syndrome, serum cortisol levels are significantly associated with fasting glucose concentration. The relationship between fasting hyperglycemia and cortisol is due to the glucocorticoid effects on hepatic gluconeogenesis and insulin secretion. Metabolic syndrome is associated with endothelial dysfunction that significantly predisposes to an increased risk for cardiovascular diseases. Endothelial dysfunction is also observed in patients with hypercortisolism. Hypercoagulability of blood is also present in metabolic syndrome. Indeed, elevated fibrinogen and homocysteine concentrations have been observed in metabolic syndrome patients compared with healthy controls. Hyperfibrinogenemia and homocysteinemia seem to be independent risk factors for cardiovascular diseases and venous thrombosis. Elevated serum uric acid levels are seen both in metabolic syndrome and hypercortisolism. High uric acid levels are regarded as a predictor of cardiac and overall mortality in patients with cardiovascular diseases or stroke. Elevated uric acid is also associated with higher risk of stroke in patients with or without cardiovascular disease. It was demonstrated that statin atorvastatin therapy is associated with a reduction in uric acid levels, along with an increase in estimated glomerular filtration rate in chronic kidney disease patients with metabolic syndrome. This effect on renal function is perhaps due to an amelioration of endothelial function and renal blood flow. Adipose tissue is recognized as an important endocrine organ that secretes a variety of bioactive peptides, termed adipokines. These adipokines exert multiple effects and play a key role in glucose and lipid metabolism, insulin sensitivity, BP, and angiogenesis. The major components of this family of adipokines are adiponectin and leptin, which are mainly produced by adipose tissue. Both these proteins exert an insulin-sensitizing effect through fatty acid oxidation and, in addition, adiponectin is associated with antiatherogenic, anti-diabetic, and anti-inflammatory properties. In obesity, insulin resistance has been linked to leptin resistance, elevated leptin, and low adiponectin levels, which are associated with higher cardiovascular risk. Resistin is expressed in abdominal fat and is also associated with increased risk of central obesity-related diabetes. However, resistin may not be an adipokine, because in humans it is mainly produced by monocytes, and its link with central obesity is debated. Excess adiposity leads to dysregulation of adipokine production, which in turn promotes a state of low-level systemic chronic inflammation predisposing to atherosclerosis. According to MIT approach, since molecular imprints of cortisol can act as artificial binding pockets for cortisol, it can antidote the adverse biological effects of excess cortisol circulating in the body that initiates metabolic syndrome. Homeopathic drug cortisol 30 contains molecular imprints of the hormone cortisol. Cortisol 30 is a great remedy for many ailments that are associated with metabolic syndrome. As such, Cortisol 30 will be a powerful ingredient of homeopathic prescriptions in the management of all complaints associated with metabolic syndrome. Constitutional medicine of the patient, selected on the basis of mental symptoms and physical generals, show it be an essential part of prescription. Incorporation of pituitrinum 30, insulin 30, uric acid 30 and thyroidinum 30 along with common anti-stress homeopathy remedies such as arginine 30, Gesell's 30, adrenaline 30 etc. produces beneficial effects in reducing the bad effects of stress and increased cortisol levels, and thereby preventing and curing metabolic syndrome and the health risks arising from its complications. According to MIT View, a combination of all the above-mentioned remedies in 30C potency 10 drops twice daily for a long period will be very effective in combating the issue of metabolic syndrome.